Yeah, we should be good.
Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Our topic tonight is co-managing complex cornea with Dr. Cecelia Koetting, who practices at the MD-OD practice Hindsight in Denver. Not Hindsight, but Hindsight. Her primary focus is in anterior segment ocular surface disease, neuro-ophthalmic disease, and perioperative care. She's a fellow of the American Academy of Optometry, a diplomate of the American Board of Optometry, an active member of the AOA, and served at local and state offices in the AOA. She was named Young Optometrist of the Year in 2019 by the state of Virginia, receiving the Vanguard of the Year award. She lectures nationally, locally, internationally at conferences, and has written multiple publications. She's a longtime friend of Optometric Education Consultants. Greg and myself, we've had her at several live meetings. She does a fantastic job. So I'm really looking forward to it. So really, with that, Cecelia, please take it away.
Thank you. I'm excited to be here, and thank you for having me. Amazingly, yes, there has actually been an update as to where I'm at. I'm actually now at the University of Colorado, but still in Denver, which is great. And tonight we are going to talk about one of my favorite things. And my history, even though more recently I've been in Colorado, as you heard, he was saying Virginia, very much a different place than Colorado. And I spent almost a decade, the first part of my career in Virginia, working at a referral center, and it was all secondary, tertiary care, and a lot of surgery. So I thankfully got a good firm amount of patients that had been post-surgical. And that's really where this lecture comes from, and my love from it has come from, is just kind of having almost this fellowship that was with my cornea specialists. And I think it's such an important thing for us to understand that this is not something we take on by ourselves, and it's not something that ophthalmology takes on by themselves as well. It is a collaborative care effort when it comes to managing these complex corneas. And whether that be pre-surgical intervention, whether this be post-surgical care with these patients, it really takes a team to take care of these patients. And just to make sure we're staying on here, we've got my disclosures here, all of which have been mitigated. And why are we talking about the cornea? Well, it's a silly question, but it is the powerhouse of our eye. And I jokingly say that, hey, look, the retina is really important, but so is the cornea. Because if that cornea isn't clear and functioning properly, it doesn't matter what's going on behind it, because we're not going to see either. So it really takes the whole eye, as we know, to make sure that our patients are able to have functional vision. And with the cornea, I'm not going to go through a full anatomy lesson here, but I think it is important to remember these different layers, because some of the things that we're going to talk about, where they're occurring in different layers, and it makes sense what the problem is and possibly some of the treatments based on where these problems are occurring. The other thing I think is worth mentioning is, did you know that there are officially now 6 layers, not 5? We have DUA, which was introduced approximately 10 years ago. It was post me being in school, where it became an official layer. So we have the A, B, C, D, D, E as far as the layers of the cornea, which I think, again, is important to remember where we're at when we're talking through some of these disease processes, as well as the treatments. Another fantastic thing that we've developed, or that has really been advantageous in cornea treatment and understanding of disease processes and looking at them, is our ability to use our OCTs for the cornea. And looking here, we can see that we can actually identify all of the different layers through an OCT, which is pretty darn cool. Now let's start off with one that I think that is very common, very common to us, something that we feel more familiar with, which is keratoconus and pellucid marginal degeneration. And we know that with keratoconus, this is where we're having corneal collagen problems, and we start to get progressive thinning in the paracentral cornea region, and this leads to steepening, causing irregular astigmatism, leading to poor functional vision, as well as the potential for needing a full corneal transplant if we have high drops or get a perforation. Risk factors for these patients, we know at this point, there's a lot that have to do with our genetics. And unfortunately, the genetic testing that came out a few years ago for keratoconus has been pulled off the market, and we don't know if anything's going to happen again with it because the company just didn't work for them, which is a bummer because it really was just this nice tool that we had added to our armamentarium when it comes to keratoconus, and deciding in some of these cases where they're really borderline and getting treatment earlier, because as we know, the earlier we start treatment in these patients, the better we can preserve their functional vision. Risk factors beyond our genetics, we know when we're talking about keratoconus itself, sleep apnea, floppy eyelid syndrome, especially as we're older, but more when we're younger and throughout life. Think about eye rubbing. There are some other genetic predispositions other than just hereditary. We have a higher risk in our Down syndrome patients, as well as our Marfan's patients, for having keratoconus. So things that are concomitant that we should be aware of. And this is an interesting slide because it talks about, you know, how many people are estimated. What I take from it, the part that I like, is how many people are estimated to have keratoconus, and realizing that it's not the same everywhere within the world, or even everywhere within the United States. It doesn't talk about it in here, but we know that if we start looking at demographics and we start looking at socioeconomic areas and prevalence of keratoconus, we start seeing some patterns in some of these areas. But interestingly enough, in the United States, previously estimated to be 1 in 2,000. More recently, in other countries, we're seeing levels as far as 1 in 375 in Netherlands. So it is much more prevalent in certain areas, and it is something that, again, the earlier we catch, it just really makes a huge difference for these patients. So watching out for keratoconus, we've got plenty of different signs and things that we should be watching for, but it's very hard to catch it early without doing other sorts of testing as far as topography, or if you have a Schleim fluid camera, so your pentacam, things that we can see posterior cornea, and looking at changes that are there in contrast to the anterior or the front portion of our cornea. But things that we might notice in clinic is thinking about the amount of astigmatism that these patients have. Thinking about, you know, unfortunately, we can talk about scissoring, and we can talk about Munson sign, things that are much more progressed keratoconus, and signs that we hope that we would catch it prior to. But there are plenty of patients out there, and I see a lot of them for either emergency or for refraction or for even dry eye disease. They think that this is what's going on, and I notice that they've got a Munson sign. I've got a beautiful photo. It's not in this slide deck, but I've got a beautiful photo of a Munson sign from a 28-year-old gentleman from last year, who I said, you know, so how long is your keratoconus? Anybody ever talk to you about these problems? He's like, my what? And nobody had ever talked to him about keratoconus. And this is a fairly with it person, and it was one of those things that it definitely, we're going to have those patients. It just reminded me, we're going to have those patients that they're naive to having a discussion about it, and it's not getting caught till later. So past that, other diagnostic equipment, as I was mentioning, placido topographers, Schleim fluke topographers are really helpful. Going back to talking about that anterior segment OCT, where we can look at cross sections of the cornea and looking for at that epithelial thickness mapping. And when we start to see these things, now that we have the advent and ability to do cross-linking, which is what we're going to talk about, it's really important to getting these patients in as early as possible for treatment to stabilize. And a few things when we're looking at the pentacam, when we're looking at our Schleim fluid, our placido discs, looking for irregular placido egg-shaped topography. These can be early signs of keratoconus. So it may not be as black and white as it is as we see in textbook, right? There's going to be a lot of cases where it's more subtle and it's borderline, and we aren't quite sure if it is if it's something that is going to turn into keratoconus, or are we just catching it early, or is this not related at all? We just have to watch those patients closely. Focal thinning on OCT, this is just kind of a photo highlighting that we can see that we're seeing a trend of inferior focal thinning on this patient's cornea. So it's an additional way that we can see earlier signs of keratoconus. And with flucid marginal degeneration, remember, this is different. This is not keratoconus. It is typically something that is non-hereditary corneal ectasia, most likely stemming from some kind of, most commonly, surgery. The ones that I've seen in the past have really been related to either having LASIK or PRK, or may have been there. I've had a few patients where I actually had PMD, but it turned out it was keratoconus when we did genetic testing. But it was so shadowed because it looked like it based on their history of having LASIK. Either way, PMD, traditionally non-inflammatory, non-hereditary, peripheral corneal thinning that slowly progresses over years. So versus keratoconus, where we really have those two areas of time where we have the big majority of our change being in our late teens, and then again in our like late 30s, early 40s, these are a slowly, continually progressive patients, okay? And when we look at them, so we look at a corneal topography, looking at the difference between them. Remember, we get with the PMD, we tend to get crab claw, right? And with keratoconus, we really get that true inferior apex on the cornea. Now, I have a question for y'all, because I like to know kind of what's going through your brains and your experiences and what your thinking is. But this is your polling question, and I'm looking to hear your thoughts on when is it time to discuss corneal cross-linking with your keratoconus patient? Do you feel like it's at the time of diagnosis, only when you see worsening or progression? Are you kind of on the throes of when it gets beyond the help of contacts or glasses? Or is it just something that you really just don't feel comfortable discussing and it's not part of your practice? And that's okay. None of these are right or wrong.
All right, let's see here. First comment I want to make, Cecelia, while we're waiting for the polling to roll in, is you nailed it on the head. One of the funnest things I like to point out to the audience when we talk cornea is, like you said, retina is important. However, we look at Ks all day long, 42, 44, 43. They're steeper in keratoconus as we're talking, but the power of the eye is 60. So if you take 40 over 60, that's 2/3. The cornea is 2/3 power of the eye. So I like always pointing out to the audience, that's why it doesn't take too much of the cornea to be unhappy for the patient to have some symptoms when it's 2/3 of the power. So
Absolutely.
All right, looks like we got a pretty good amount of people replied. So I'm going to end the poll. I'll share you the results.
I want to see. Yay, I like this. That's great. And that's what we want, right? This is really what we've all been striving for. And especially now we're 2016 FDA approval for cross-linking. The earlier, we all know, the earlier we get them in for cross-linking, the less potential progression for these patients, right? And that means a lot for them, for the functionality of their life. Think about a 17-year-old who isn't going to, thinking about going to college, about going into sports, whatever. This could make a huge decision, change in their decision as far as where they're going to go from there. And then think about the person who may be getting ready to have another shift and they're in their late 30s, early 40s. And we know that this could possibly be that tipping point to now maybe they need a cornea transplant. So I agree. Absolutely. At the time of diagnosis, if you can, like I said, none of the others are wrong. However, that would be my hope, is to see that we all eventually get there to do it as soon as we possibly can, to have that discussion and refer them, even if it's not us or we don't want to get into a really big detailed discussion. I think it's really important to give them the option and send them to somebody who will. So
And for the three people that don't feel comfortable, that's why we take education like this, and
Got
hopefully
it.
that will make them feel comfortable, right?
you got it. Yep.
There's a
So
question in the chat box. Hold on one second. It says, since the advent of cross-linking, has 20% of the transplants decreased, ? And then someone wrote, wondering the same thing. 20% sounds like a lot.
yeah, so it is definitely decreased. I think that was a statistic back from a number, I think it's like 3 or 4 years ago. I don't know what the statistic is now, but I will tell you just from working in a corneal practice with multiple corneal surgeons, as well as now currently in the university, I'm seeing a whole lot less corneal transplants. However, remember, the transplants aren't the people who are younger. The transplants are typically the people who are, as they're aging and continuing to progress. So I think that even though, yes, it's less, which is great, I think we'll see in the next 15, 20 years, maybe that number is going to continue to decrease even more significantly, because the people who now are the age that in 15, 20 years, they may need a cornea transplant, we're going to hopefully have less of them because we're treating them now. So that's my thought. Time to treat. So patients who aren't stable, we know when we talk about insurance and things like that, especially when we're talking about cross-linking, we have to show that a patient is not stable. That really is a pretty low threshold. And I think it can be argued pretty easily these days, just talking about refractions, right? If you send somebody to a surgeon, send them with all of your previous refractions, even if you're not doing anything more than your auto-Ks and refractions. That's a lot of data that can be very helpful to argue with insurance that somebody is progressing. But obviously they're not stable when we've got continuing steeping of that cornea. They're continually changing with their glasses prescription. Patients who are starting to have corneal scarring, that's not good. If we're starting to have endothelial striae, we're starting to see all of these other things, high drops. That is not a stable cornea, and that is got to get treated, whether it's cross-linking or something else. We need to move past probably what we're doing at that point. Even if a patient is stable, we do want to still treat, as we've been talking about. Now, what is that level? I say that always to me, whether that be a lateral referral to an optometrist, if you're in a state where we can do cross-linking like I am. I do a lateral referral. It doesn't mean it has to go to an ophthalmologist unless you're thinking it might need a corneal transplant, but you can always defer to a friend, see what they think, and go from there. But they should at least have a consultation, in my opinion, to talk to somebody about cross-linking or intacs or some of these other things. And then fit them with our GPs, our sclerals, all of those things that we know, depending on what level they're at, we're going to get them the best possible vision we can. So treatments, when we're talking about surgical treatments, we've got a couple of different things. Corneal intacs is also another treatment that I don't have listed on here. I do apologize about that. But corneal cross-linking, corneal transplant, and then corneal intacs. Intacs would be at the same level as corneal cross-linking. There has been shown to be some decrease in progression in those patients as well. However, it is now being argued that these patients probably should be cross-linked and then intacs or some kind of scleral lens versus just doing intacs alone. Now with corneal cross-linking itself, this is just reminders, UV light and photosensitizer that's used to strengthen the chemical bonds in the cornea. So we're actually using oxidative deamination reaction with the collagen to try to strengthen those bonds so that it stops. Because remember, we've got a malleable, movable corneal stroma tissue, and it's causing that to become misshapen. And that's really where the problem is. So if we can get those to stabilize, then we, in theory, keep there from being progression. FDA approved with Epi-Off in 2016. I would estimate in the next couple of years, Epi-On will be also FDA approved. As a side note, the practice where I was at, because, MDs can do things a little different sometimes. They were all doing epi on. So I would say 90% of my actual experience with corneal cross-linking has been, and co-managing has actually been epi on patients, and they have all done very well. So I'm excited to see when those trials come through. And it is not just indicated for keratoconus. It is also indicated for pellucid marginal degeneration, tearing marginal degeneration, and post-refractive surgery ectasia. What is it doing? So remember, we're talking about the UV light and the riboflavin. So the riboflavin drops, which is the Photrexa, and then there's also another. I'm going to put this up here. So we've got Photrexa viscous, and then we've got Photrexa regular. And depending on what type of procedures being done, epi on, epi off, the surgeon, as well as the corneal thickness, is going to depend on which type of Photrexa they use, the viscous or the regular. And the viscous actually helps to thicken up the corneal tissue. And there's a minimum of 400 microns that's needed to be able to perform epi off corneal cross-linking. And that's just because, again, dangers that can happen if it's less than that, to possibly damaging the endothelial cells. So epithelium's removed. The cornea is soaked with either Photrexa or Photrexa viscous for 30 minutes. They check for flare. This lets us know that it has been absorbed into the tissue, and then it's going to react to the UV that the cornea is then going to be exposed to. Once flare is observed, that also tells us it's absorbed, so we can check the corneal thickness. And then after that, they go ahead and irradiate for 30 minutes. Contact lens, bandage contact lens is put on to protect that front surface, very similar to a PRK at this point, right? Contraindications, as I mentioned, corneal thickness less than 400 micrometers. Sorry. And that's epi off. And again, that's because of just concerns for damage, but it's kind of like not a hard and fast. If they're kind of close to 400 microns, or they think that they're probably going to be close to 400 microns, they may still let them do it, because again, that Photrexa viscous will actually thicken up the cornea as well and allow them to be back into that area where they're safe. Prior herpetic infection, because what activates herpes? UV light. Yeah. So there's some concern there. Again, not a hard and fast. I've got plenty of patients where the surgeon elected that it was still worth it to do it for them. However, they were given a very hefty dose of oral antivirals prior to and for 3 months post. A concurrent infection, again, no, they're probably not going to do it, but there's been some studies that have actually been looking at corneal cross-linking as a way to treat ulcers, to decrease the bacterial load and help these patients. So I don't know what's going to go on with that, but in typical, if we're doing this for somebody who has keratoconus, if they've got a concurrent infection, we're probably not going to be doing that. Severe corneal scarring and opacification. Why that? Well, guess what? Unfortunately, this is not going to fix that. And if they really have bad enough that it's affecting the vision, they probably need a corneal transplant at this point. History of poor epithelial wound healing. We may be thinking about a person who has, well, we know herpes, which can also cause neurotrophic keratitis to be poor wound healing, somebody who's diabetic. So things that would preclude them from being able to heal properly from having the epithelium removed prior to the surgery. This may be a patient that would be a better epi-on candidate. And then obviously severe ocular surface disease and autoimmune disorders. So what should we expect, right? So if we're co-managing, or at this point, depending on the state, if we're treating and we're now seeing these patients, again, my experience is primarily epi-on, but I will talk about epi-off as well. The big things that you're expecting to see day 1 and week 1, some SBK, you're seeing a lot of irritation if it's epi-on, a slight haze, possibly some heaped epithelial central. If it's epi-off, day 1, you're going to have an epithelial defect, right? It's going to probably be about 7 millimeters, very similar to PRK. Week 1, you're probably going to be 100% reepithelialized. However, you may have that healing epi ridge right in the central. By month 1, there shouldn't, and you might have some haze too. So by month 1, though, that haze should be gone. All of them, whether it be epi-on, epi-off, it really kind of tends to be very similar at this point with month 1. Steepening You actually will have about a half a diopter of steepening within that first month in these patients. And then over the next 3 to 6 months, you're going to get the flattening. Okay. And depending on the patient, depends on how much. So we don't tell these patients, oh, hey, we're going to reduce your astigmatism, but guess what? We actually are probably going to a little bit, and we're going to get a little improvement as far as the amount of steepening of that cornea. And again, depending on the person is depending on how much. I see usually about 3/4 to about a diopter and a quarter of improvement, which is still pretty significant. By month 6, we've got about 3/4 of flattening at that point. So they're pretty stable. If they need to get refit, this is definitely an okay time to do that. By 1 year, they're usually stable. Now, what are our complications? Well, guess what? I keep saying PRK because the complications and everything are very similar to PRK. And I think that's just a really good thing that we're familiar with to kind of keep in mind. So as that epithelium's healing, there's the risk for an infectious keratitis. There's a risk for a herpetic flare. And again, that's why we ask the patient if they've had it before in the past so that we can put them on antivirals before and after. If they have a thickness of less than 400 when they're treated, we may actually end up with some endothelial cell damage. And then again, that persistent epithelial defect. And if that happens, this may be something that we just have to really baby that front surface to help it to heal so that they can end up without scarring. Hold on, I'm going to cough. It is that
So
time.
you warned us on that,
Sorry.
so Phil go right ahead. So
It is that time of year. Okay. So long-term maintenance, what are we doing for these patients? You know, the more we feel comfortable with it, the less we're seeing them as often. At first, I was probably seeing these patients every 3 to 6 months after 2016. That's because I was really interested to see what was going on and how they were going to react. And I was also really interested to see what the difference was between our experience with Epi-On was versus the FDA-approved Epi-Off. So close monitoring, though, we do want to watch them every 3 months as far as up through the first year. And then we can move over to yearly. Every doctor is going to be a little bit different. So that may not be how you do it. Or the doctor that you're co-managing with may actually have you do it more frequently or less. But the big idea is that we definitely want to also make sure that we have a conversation with these patients, that we're counseling them, anything that's a risk for them to continue to progress or in the future progress. So eye rubbing, making sure we're treating other ocular surface disease, we're treating allergies, anything that could be a potential for causing them to do something that might cause progression or kind of regression at that point. So the alternative to this, corneal transplant, right? And obviously this is much more invasive, and they're still going to continue to have patients. We will always have patients, in my estimation, as far as probably my length of my career, there'll still be corneal transplants, not just for keratoconus, but for other things as well. Now, when we talk about corneal transplants, some of the indications and contraindications with these, there's multiple different reasons that it may actually be used, not just talking about keratoconus, patients who have deep scarring, somebody who has endothelial pathology that has caused scarring that goes through the stroma to where they may need a more comprehensive transplant than a DMEC or a DSEC, somebody who has a perforation. We talk about neurotrophic keratitis, and we'll talk about it later, but that is a risk for that if they get to stage 3. And then any kind of diseased cornea where it's really affecting more of the whole cornea versus just a single layer, which thankfully at this point, we're pretty darn good at doing transplants that are partial. So contraindications, 2 of these I would say are not hard and fast. One of these is a pretty hard and fast. So glaucoma, not a hard and fast contraindication. The reason that they talk about that is because it is a little bit more difficult to check the patient's pressure, but that's not going to stop us from doing a corneal transplant. I've got lots of patients who've had corneal transplants that have glaucoma. It also unfortunately puts patients at a little bit of a higher risk to develop glaucoma after they've had a corneal transplant. The other one, previous graft failure. Yes and no. Depends on how many graft failures they've had, and it depends on the surgeon. I will tell you, I have patients who've had upwards of 4. 4 was the one of my corneal surgeons, 4 was his max. He said, nope, I'm done at that point. What might be done after that, depending on the surgeon. I worked in Cincinnati during my residency. There was patients who had K-Pro, which is actually this like, kind of looks like it's like a spool for thread, that you can see through. And so it's actually put in and everything kind of scars around it so that the patient can see. But depending on the surgeon, they just have their own levels as far as, when they say, no, we're not going to do another one, because there is, in fact, a diminishing return each time you do a corneal transplant. The hard and fast one, vascularization, right? So why does a corneal transplant do very well? Why is there a very low risk of rejection with corneal transplant versus when we talk about other types of transplants like kidneys and, I don't know, pick something, right? It's vascularization. It is blood vessels, right? So the cornea is a clear avascular dome, right? And the avascular is so important because it is not allowing our body's natural immune response to get to that tissue. So if somebody has vascularization that's getting into the area where that tissue needs to go, how well is it going to do? It's not. So the vascularization is really something that they tend to be pretty consistent on, as far as, no, they're not going to do a cornea transplant on that patient who's in that bottom picture. Now, what do we expect post-corneal transplant with these patients? Day 1, they're going to look like a little bit of a hot mess, to be honest. They're not going to feel awesome at all. They're going to have moderate to severe stromal and corneal edema, probably going to have a nice old subconch heme. Usually expect about 1 to 2 plus cell and pigment mix in the anterior chamber. Vision's not going to be awesome. And like I said, they're not going to be feeling pretty good. By week 1, they bounce back pretty darn quick, okay? They will still have a lot of swelling, and it takes about a month to get most of that swelling to go. Some patients, it takes longer depending on other things going on. But at week 1, we'll still have some corneal edema that might be their vision is improved, but it's still pretty decreased. You're not where we're getting, right? This is not going to be the end. AC, I would still plan to see about trace to 1 plus cell in these patients. Month 1, most of that edema should be resolved at this time. We can start talking about refraction. We're going to start watching pachymetry, atlas to monitor. Usually we hold off on doing any kind of like final refraction until later. And part of that is because at month 6 is when I get to start doing, my surgeons would have me start doing selective suture removal. And can't really do that if they do a running suture like they had in that first photo. But if they have single sutures, what you can do is you continue to do your topography and you see where the astigmatism is, and you look for the most amount of astigmatism, and you actually release sutures in that area so that you release out some of that astigmatism, so that we're getting them possibly down to, we usually aim for about 3 diopters or less of astigmatism, because that's much more functional for contacts and glasses for patients. So that's kind of cool. But that's one of the reasons for me, I hold off, or we would hold off on doing a final refraction. And that's not to say that you can't get the patient something in between, because 6 months is a long time, but that's the thought. Now, complications, we got a whole lot, right? We got an open globe surgery here, right? An open sky surgery. So infection is obviously the biggest one, but the surgeons are typically doing a lot of antibiotic intracamerally, so injecting it into the eye itself during surgery and at the end of surgery, and then we're putting them on antibiotics after surgery as well. Concern for damage or lens to the iris, that's going to be a surgeon problem. That should not happen, but I'm sure it does, especially if the patient moves. The bigger thing, though, is going to be more post-surgery, looking for iris incarceration of the wound. So if somebody accidentally rubs the suture, or the suture isn't not positioned properly, and we've got leakage. So if we've got wound leakage, there's risk that the iris might actually get pulled out into that area, and then we've got entrapped iris, which is not ideal. Flat chamber, looking for donor failure. Usually you're not going to start to see failure. If your patient's going to fail, it's usually later because they're on so much medication drop-wise. I would have to say the earliest I've ever seen a failure was 1 month, and that was because the patient was not compliant with their medications. Persistent epithelial defect, that can occur because the limbal stem cells, if they aren't waking up and working with the new transplant, we're not having anything to replace those epithelial cells, are we? And so that's going to be an issue. And then obviously open globe, infection, endophthalmitis, but not just primary endophthalmitis. You can actually get the latent endophthalmitis that can occur 3 to 4 weeks after surgery, and up to, I've unfortunately seen it up to about 6 to 8 weeks, I think was the latest I saw a patient who had that. Other complications long-term. Well, dehiscence is the big one, right? Sometimes we take these sutures out, usually after a year. If it's a running suture, they'll take it out. Some surgeons leave it. Even if the sutures are gone though, if the patient falls, I had a patient who fell in the middle of the night and hit their head and said they fell, a bunch of water come out of their eye, and came in, and lo and behold, the cornea transplant was no longer attached all the way. So that can happen. Glaucoma, talking about that earlier, that these patients do have a higher risk long-term for developing glaucoma. Wound dehiscence, graft rejection. The bigger thing though too that we end up typically dealing with is the refractive error astigmatism. And for these patients, depending on the surgeon, I've found that I feel like it's about 50-50 on the surgeons. About 50% will keep them on a topical steroid to decrease the rejection rate long-term for life. 50% won't. If not, if anything else, they're probably on a very slow taper with the topical steroid for about 4 to 6 months after surgery. Some will require long-term oral antivirals if the transplant's related to prior simplex or shingles. And, we talk about the PK needing to be redone after about approximately 20 years. I've got plenty of patients who've had theirs for 30 or 40, so that's not a hard and fast. Okay, so we're going to switch gears. Okay, we're gonna start moving back through the eye. So looking at this, we've got a polling question coming up here. We know we've definitely got guttata, right? We can see that beaten bronze metal appearance or orange peel appearance. That is definitely some endothelial guttata, some healthy guttata going on there. And when we talk about guttata, we talk about guttata and Fuchs. And Fuchs dystrophy itself is actually a consequence of developing guttata. But here's what I want to hear from you. Here's our next polling question. Guttata is considered Fuchs when? Choose the most appropriate answer. There is less than 700 endothelial cells on microscopy. The patient becomes symptomatic. There is grade 3 guttata. There is no current consensus.
And you are all caught up in your chats. Joe launched the handout at 8:23. Thanks for doing that, Joe.
Perfect.
And
if anybody has questions as we're going along, please don't hesitate, put it in. I want this to be helpful for you.
Well, you answered my question. My question was, I have about 50% of the surgeons that keep them on a maintenance dose of loteprednol or FML, and I get some that say don't do it. And I was wondering what your thought was, and you said 50%. So
I would say it's about 50%. The harder question though is those that come to me that look like they're fine and they aren't having any signs of rejection and they're not on anything. Do I want to put them on something because that's just something that I'm so used to? And I did for a long time. And at this point, depending on how long they've been off, I'm okay with leaving them if it's been more than a year and they've been off their steroid. If the surgery has been at least a year and they've been off their steroid for at least a year after that, then I feel okay if they're off of it. But I'm not going to stop somebody who's on it.
Yeah, I've had plenty of patients that have stopped, and the surgeon wishes and they don't want to go on it. And I have some. I actually now I just said this to a patient today. I'm almost 20 years in practice, or 29 years in practice, And I have a patient with 25-year-old, corneal transplants. And
Yeah.
they're still hanging in there. So that's pretty cool.
It's impressive.
There you go. There are your results.
Ta-da. Good. I like it. You're correct. There is no current consensus. These are actually 3 answers I've gotten from 3 different cornea specialists. There's no consensus. So, don't feel bad when you don't know when to call it Fuchs or Guttata. You know it's Guttata. It's always Guttata because that is an actual finding, right? But when we talk about Fuchs itself, you know, you may get varying answers from people, and that's okay. It does not mean you're wrong. It just means there's no consensus. So talking about Fuchs endothelial, why is this a problem? What is it? What are we talking about? So remember, the guttata themselves are actually focal areas of dysfunction within those endothelial cells. And the endothelial secretes the excessive amounts of abnormal collagen into the Descemet membrane, which then accumulates and forms these little protrusions into the anterior chamber. And that's what we're seeing as guttata. I like to describe it to my patients as little chips out of their windshield, because it's kind of what it looks like. But the problem here is that this means we're losing endothelial cell density, and then we're losing efficiency and function of those endothelial cell pumps, which are really important because they keep the cornea a dry sponge, right? And when that fluid starts making it into those layers, then we're going to start getting expansion, we're going to get swelling, we're going to get hazy, and that's going to compromise their vision. Tends to be bilateral. It may very much, I would always agree that it's asymmetric. More so, they're pretty close, but there's a lot of asymmetry in these. Very slowly progressive. Usually we'll see it in about the 4th to 5th decades. We'll start to see guttata, sometimes sooner. Autosomal dominant with incomplete penetrance, so it actually does have some genetic component to it. And I would absolutely agree, women are 3 times more likely than men to have it. I would agree that that's what I see in clinic as well. And when we talk about endothelial cell density and going back to looking at endothelial by microscopy and the cell count, why talk about 700, right? Well, where that kind of comes from is that we're born with about 3,000 to 4,000 cells. And by the time we're adults, our late 30s-ish, we've got about 2,500 cells. And then by the time we are into our 60s, 70s, 80s, we're down to about 2,000 cells. I think one thing that's of note to remember is that you will lose more cells as well, because in our later age, not just with the natural aging loss, but think about the amount of surgeries. We lose about 4% of our endothelial cells when we have cataract surgery. And if you're lived long enough, you're going to be lucky enough to have cataract surgery. So we're going to have that in there too. But if we've got somebody who's got 700 cells, that's kind of where that 750 number comes from, is that that's less than half of what we're supposed to have by the time we are into our old age. So that's a pretty critical number. And that, if you have it by microscopy, there you go, that you could use that as your way to label when it is Fuchs. But what happens is when we have less of these cells, our body starts to increase the size of those endothelial cells to make up for the space. And then when we do look on by microscopy, this is actually kind of fun to look at. We can see what it looks like in these patients. What does guttata actually look like in these patients? So that is kind of interesting, as well as you can see the differences. So in that in that third photo, we can see the different sizing of the endothelial cells themselves as well. So that's that polymegathism. So the changing in the size, the enlarging in the size to compensate for the loss of those endothelial cells. Now, what do we do for these patients? Non-surgical, we've got a couple of things that we can do in clinic. Muro 128 or a sodium chloride solution or ointment. I like to use the ointment at night. Why? Well, what happens at night? Our eyes are closed, right? So we get less oxygen permeability and our cornea tends to swell at night. So by using the ointment at night, in theory, we're helping to work with our body, not against it. Sorry. Other things, topical steroid, and then a blow dryer. And I'm going to pause for 2 seconds. Sorry.
I think it's really cool with the picture before that, as you're getting that throat taken care of. If you go back one picture, that middle picture that you were showing of extended wear contact lens. I mean, I think I put that in my office to show people, hey, look, if they can explain to them this is the way it's supposed to look, and look what you're doing by starving that cornea. That's pretty cool.
Yeah,
And then you
picture.
got a question that rolled in there. What about fresh coat for early fuchs?
Yes. Okay. So good question. And so yes, fresh coat. Okay, here's the thing with it. Yes, I will say I like it, and I like to use fresh coat during the day. So I will typically use sodium chloride solution at night, or the ointment at night, right? Just to help and have something that's more consistent. And then I like to use fresh coat during the day. I do find that works really well. There are some osmotic properties to it that they think helps to actually stabilize the cells. They are really vague about it, and when you ask them for evidence, they don't tend to have any. I'll tell you anecdotally, I do find that it does help, but I can't get a straight answer. So blow dryer, and I love to talk about the blow dryer. I don't do it. I never have. I've never suggested it to patients, but usually when I talk about it with colleagues, I will always have at least one or two people who say, yep, I've had patients who do that. And yes, I find that it is very helpful. Sorry. And they find that it's actually helpful. So take it or leave it. There's another option. Now, past that, what do? We are talking surgical, and when is the time for intervention with surgical? The time for intervention with surgical is obviously a patient who is consistently symptomatic, and none of our other palliative treatments are working for them. The other time is when we're talking about cataract surgery, because what did I say? We lose about 4% of our endothelial cells during cataract surgery. So now we've got a patient who maybe already has 3+ gutata. They're struggling a little bit. We're about to put them through a surgery where they're going to lose 4%. They don't have 4% to lose. So that's a good time is to do a combination surgery at that point, is for those patients. When we talk about surgeries, very rarely is PK done anymore for these patients. This is somebody who is a very progressed, has scarring that has occurred that has led to decrease in vision, and that's not something that's going to get fixed with a partial corneal transplant. The benefits of the DSEC and the DMEC, though, is with the partial corneal transplants, it's a much faster visual recovery in these patients. They tend to have much less astigmatism and ametropia. With the sutures, we're looking at maybe 2 sutures at the incision site that I'm going to take out at 1 month. So much less, distortion to the cornea at that point from pulling, as well as concern for later suture removal as they get older and those sutures break. Other things, less risk for epithelial complications, less risk for rejection in theory, more globe stability. So overall, everybody's kind of moving in this direction. Now, when we talk about the DSEC versus PK longevity, DSEC themselves only came out about 20 years ago, or we're almost to 20 years. We're not even at 20 years at this point. So we just don't have the data to say that they last as long as far as survival rates. But what you can look is at some of the other data, looking at 5 years and looking at that endothelial cell loss, right? Because that's where the problem was. And we found that in the DSEC versus a PK, there's 53% endothelial cell loss at 5 years versus 70% at 5 years in a PK. So we could kind of extrapolate to that to say, hey, in theory, we should have a similar, if not longer, graft survival rate for these patients. Other indications that we may do this for, if a patient has not just Fuchs, but anything where there has been damage to the endothelial cells, whether it be retinal surgery, when we have oil that's left in there that makes its way to the anterior chamber, it starts to cause damage to those endothelial cells and break down. So that may be a reason to do it. If somebody has a scar endothelially, we need to deal with. That might be another thing to do or to use it for. Another thing as well is iris loss or atrophy tends to, or aniridia, patients with aniridia and or loss of their iris itself tend to have a breakdown of those endothelial cells for one reason or another. So they may end up needing to have a partial corneal transplant. What do we need to do for any surgery? It says for, we're talking about this surgery, but we need to make sure that before the patients have any surgery, when we're talking about the cornea, that we're trying, and other than PK, because, well, to be fair, the PK is replacing the whole thing. We want to optimize our ocular surface. We want to normalize lids. We really want to treat all underlying ocular surface disease. We really need to prepare this cornea so that it has less stressors on it, eliminate any extra inflammation, eliminate any potential for these patients to have excessive amounts of bacteria that could lead to a higher risk for endophthalmitis. We want to make sure we're controlling their glaucoma and keeping that stable, considering any potential glaucoma medication changes now that we have many options as far as preservative free. I think that's a really important thing as well. And I think it's also important to make sure that we're educating these patients on what to expect. So the DSEC itself stands for decimate stripping endothelial keratoplasty. And so it is obtaining, we're using partial corneal transplant. Now, when they do the surgery itself, we've got DSEC and DMEC, and we're going to talk about that in a second. So I want to get to the picture. There we go. So when we talk about DMEC versus DSEC, the difference is the Dua's layer. You remember me talking about Dua's layer and how that's the new one? Well, it is the one right above the decimate membrane, and there is some thought that there is a little bit of our immune system and some higher risk for immune reactions in patients who have a DSEC versus a DMEC. So a DMEC is a newer procedure and it's thinner than a DSEC. Now, we don't see it as often, and part of that I'll talk about in just a second, but both of them have the same indications. The exclusions for both of them would be the same thing as well. Anything where we see more corneal scarring, where we're talking more stromal scarring. And then looking at the surgery itself, the surgery is almost identical. They go into the patient's eye. They remove the patient's endothelial cells. So they do an endothelial cell stripping. They then prep the donor. They don't prep the donor prior to taking care of the patient's cornea first. Reason being, if they mess up, they can turn it into a PK. You can't go the other way if you've already prepared the donor tissue. So they prepare the donor tissue, DMEC, DSEC, depending on which one. It depends on how much tissue they're removing from the donor cornea. They then roll the little cornea up like a fruit roll up. They put it into, so they take the DMEC or the DSEC and they put it into the anterior chamber. They unroll it and they use air to push the little piece of tissue up so they can centrate it. So they can put it in the center. And they keep air in there so that it helps to actually push that donor tissue into place and helps with the adhesion of the donor tissue to the patient's tissue, which is kind of cool. Now, imagine you've got, so going back to why do I say one doctor might prefer it versus another, a DMEC versus a DSEC? Well, there's a learning curve. I had a phenomenal surgeon that I worked with, and she did amazing DSECs. She had patients who were 20, 25 a week after. She was just like a rock star. Okay. She was like, okay, well, I'm going to learn DMEC now. I'm going to, we're seeing good response. There's in theory some benefits to being able to do a DMEC versus a DSEC. Well, here's a problem. When you have a very thin piece of tissue and then you make it even thinner, how easy is it to manipulate that? Not very. And so for her, that was some of the problem, was being able to manipulate the tissue and getting it into position. So she said, you know what? I actually do D-sex very well. My patients do phenomenal. I'm going to stick with that. We had another surgeon who came in, and for him, he was a little bit younger. And in his residency and fellowship, he came in straight from fellowship. He had only learned DMAC. So that was all he knew. And it just made it easier for him because that was what he learned. And his patients did very well as well. But it really comes down to, I feel, when we're talking about cornea surgeons, their preference is just based on what works well for them and what they've learned when it comes down to DMAC versus DSEC, especially at this point. What's being taught, I think at this point, most are just being taught DMAC. So we'll see what kind of comes over the years. Now, talking about that bubble, this is one of my post-day 1 patients. And so when they come in day 1, we're going to take the patch off. They have to remain post-surgical for 48 hours, depending on the surgeon, 24 to 48, on their back. And that's because, again, we want that air bubble utilizing gravity and going up and helping to hold that donor tissue in place. And so when I see them, I want that bubble to be at least 30 to 50% of that anterior chamber. And this patient is just right there. I'd say they're probably 35 to 40% of that anterior chamber. That's the size of that bubble. And that's good, because if that bubble is not at least that much, that's not going to be enough air to last for the next 24 hours before they're allowed off their back and make sure that we're getting adherence. The other thing that we're looking at this day is to see, is the graft actually attached? And the way that we do that is a nice narrow parallel pipe head, and you're going through and going across the tissue. Now it's going to be swollen. You're going to see some ridges and some endothelial striae, but what you're looking for is a break in the beam. So if you go through and you have your beam on the anterior portion of the cornea, and then you see that there's another little beam behind it touching, or, catching some tissue, and there's a gap between, that tissue's not adhered. That you have a dehiscence at that point. The endothelial tissue the graft tissue is pulled away, unfortunately. And when we're watching these patients, thankfully, again, like I said, they tend to recover pretty quickly. Week 1, 2070, this is the average. This was not my rock star, but day 1, about 2,400, because they're usually looking through half a bubble. Week 1, we're about 2070. Month 1, 2040. We're by 6 months to a year, 2025, 2020. Now, what complications? We already talked about. The big one is really looking at that graft centration and looking at that graft recipient interface, especially within that first one day to 1 week, to make sure that it's adhered properly. The other thing is looking at the interface itself throughout, because we can start to get some haze. And that can occur anywhere between about a week and a month and last as long as 6 months to a year. It was maybe 20% of my patients would end up with this haze. And you keep them on the steroid just to keep it, to decrease the inflammation. It's just the body's inflammatory response. The other thing, obviously, because of that, because we're keeping the patients on steroids for so long, making sure, are they a steroid responder? We got to watch that. Looking for CME in these patients. That is another risk for them, as well as retinal detachments, because of the area that we've been manipulating. So when we talk about a dehiscence, this is one of the things with the DMEC that is actually, because that's a thinner tissue. The surgeon that I worked with, who came in from fellowship, he always had us do an OCT angiography, or sorry, OCTA, our anterior OCT on these patients at day 1, because he wanted to know, was it on? But because the tissue is so thin, it does make it a little bit more difficult to make sure, is it completely on? But guess what? This is what it looks like if it's not attached. This one's a DSEC. It's a little bit thicker, but same idea. Guess what? Nope, that tissue is not where it's supposed to be, unfortunately. And that's not what we want. Now, long-term, what do we do for these patients? Similar to what Greg and I were talking about, trying to decrease the risk for long-term rejection in these patients. We're typically going to keep them on long-term topical steroid to help reduce that rejection rate. again, because it didn't start till about 2003, we might be getting some of that 20-year data coming out now, and which means I'm going to have to update my slide deck. And I want that. I want to see what is the longevity here. What are we looking at? And I also want to see what is the rate of, how many PKs are we doing versus as we've had these other advents, what other, how many PKs are we doing versus the other surgeries for things where we used to just do PKs. So that'll be interesting.
Cecelia, on that person that had that, that OCT, would they take them to the operating room and maybe put another bubble in there and kind of maybe hopefully like get it back up there? Is that what they would do?
It depends on the surgeon. I have seen air injected into the anterior chamber at the slit lamp in the room. But essentially the idea is, yes, you do want to refloat these patients. And the question is at that point, depending on how dehisced it is, where you can do it, because if it's really off like this one, now they're probably going to take them up to the surgery, to the surgical suite. And they may actually even use SF6, which is a gas, and it's heavier. So in theory, a heavier gas may help hold it in place, especially if it's already dehisced once. So that's a good question.
Cecelia, any thoughts on DWEC? Are you going to talk about DWEC at all?
I'm not going to talk about DWEC. Will you tell us?
Well, yeah, I mean, it's the same procedure, except there's no donor tissue. It's just stripped away and they let it kind of come back in. I've
That's
seen it.
definitely-
It is slow healing.
Yeah.
You get this really distinct honeycomb cornea. But it is probably about 3 months recovery, but in some patients it does seem to work pretty well, and there's no donor tissue.
I have not worked with any doctors that have done that, so that's good. I like to hear that. I've heard of it, but that's not something I've gotten to see in clinic. So, but you said about 3 months to heal.
Yeah, because it's sort of like the reverse of an SK, superficial keratectomy. It's the reverse of it.
Yeah.
And it's got to come in, and you're gonna get a really dense honeycomb appearance to the cornea that just gets smaller and smaller and smaller over time.
Yeah.
But I had a patient who had to undergo that before cataract surgery, and I think we're still working with her, and she was quite anxious, and having fingers vision for so long.
Yeah.
Then she, after about 3 months, she starts coming down and coming down.
Yeah.
We always believe that dead endothelial cells, it doesn't regenerate, but it does seem to come back.
Which is interesting because, we talk about the endothelial cells you're born with, the endothelial cells you die with, but it doesn't mean that there's not turnover during that time. We just happen to have less. Yep. Wonderful. Thank you for that.
Yeah.
One more comment. Go ahead, Joe.
It takes out the whole issue of any sort of graft rejection, displacement, and just like I said, it's like a reverse SK.
Yeah.
One more comment, and you kind of touched on it, Cecelia, is that, someone has a cataract and they have Fuchs or Gutata and they're going to do a transplant, and maybe the surgeon doesn't feel comfortable doing both at the same time. They'll always do the cataract first and then take the patient back. I just want the audience to know that, because as you said, that 4% loss, they're not going to go in and do the DSEC or DMEC first, then go back and do a cataract surgery where there's a chance of damaging 4%. And that's in a good surgeon, right? So that's your good surgeons that's out there. So I just wanted the audience to realize that cataract will always be first. Let the eye heal if they're going to separate it, and then DSEC, DMEC. Yeah.
And that's a shame too, that they do that, because that also means that their cataract, the IOL will have been calculated differently. So definitely make sure if your patient is going that direction, they don't get a premium IOL.
Correct.
My thought on that one. Yeah. Okay. To the anterior we go. So we're going to talk about pterygiums, our beautiful wing-like ocular surface lesion that comes from limbal conjunctiva within the palpebral fissure. progressing to the cornea. We know we typically see them at the 3 and the 9. The most common causes of this is going to be related to UV exposure in our patients and increased inflammation over their lifetime. So ocular surface disease does what? Creates inflammation. Inflammation makes this worse. So it's not just UV exposure, but that is definitely a huge part of this, if not majority, right? I have lived in multiple different areas. I lived in Arizona for a year and would see so many patients there because we were in Tucson. So just the amount of exposure to sun, the closer we are to the equator, the more intense it is. And so we get more likelihood for pterygiums to occur. I did a number of trips for SPOSH when I was in school, and we would see these very aggressive double pterygiums just straight across the eye. Amazingly, here, Denver, we have how many days of sun? Majority of them, amazingly. Didn't realize that till I moved here. But we have a lot lower rate of pterygiums here because I don't know why, but everybody's really good about wearing sunglasses, and I very much appreciate that. So, location, right? The amount that we're going to see, how aggressive they are, that's really going to, our geographic area is going to play a little part into that. Most of the time they're asymptomatic, but they can, remember, induce astigmatism. And the big concern is, are they to the point where they are crossing into our visual axis? And that's going to create an issue. Now, what do we do for these patients? Well, if we see that they're starting to develop a pterygium, and to be frank, even if they aren't, we should be controlling ocular inflammation and ocular surface disease anyway. But in these patients, even more so, we need to make sure that we are being aggressive, right? We are treating the inflammation, and we have plenty of options to do that. Cyclosporin, our lifitegrast, we've got preservative-free artificial tears at the very least, right? Topical steroids if they're having a flare, because remember, we can have pterygiums that get inflamed. We just like we can get with a pinguecula. So you may need to use steroids occasionally to calm it down. Now, beyond that, when we start talking about either a patient where it's already encroaching a fair amount into the cornea and they are getting ready to have cataract surgery, and we know it induces astigmatism, it may be a good idea for them to have surgery prior to having cataract surgery. So having pterygium surgery prior to cataract surgery, or if we have somebody where it's already affecting their visual access. Those are the patients we typically will start to think about. Now, what is cataract, or what is pterygium surgery entail? Well, a nice resection. This was one of my surgeons doing a pterygium repair on a patient. So they go through and they actually are removing not just the portion on the cornea, but they actually are making a resection into the conjunctiva as well. Now, what do we expect? You can imagine looking at that. That's a pretty gnarly surgery, right? That's going to look a little rough on day one, and it does, right? So day one, they're going to definitely have an epithelial defect where they removed the portion of the pterygium on the cornea. They will definitely have conjunctival injection. They will have, it depends on the surgeon and what they do. They may have conjunctival glue. They may have sutures. They may have cauterization, depending on how they like to close their wound and kind of tighten up the area. But you want to make sure that you're checking the wound site to make sure it's doing okay. You also will probably have a nice size conjunctival hemorrhage in that area as well. By week one, most of the time, so going back to day one, they will have a bandage contact lens most of the time, again, to protect that epithelial defect, and want to make sure they're staying on that antibiotic at the very least until you remove that bandage contact lens. Anytime we have a bandage contact lens, which gets used quite a bit in corneal surgeries, we need to make sure we're using prophylactic antibiotic, because as we all know, what happens when you have a contact lens in your eye and you sleep in it, just the risk for ulcers and all sorts of things increases exponentially. So week one, if the epithelial defect is completely healed, which usually it should be, you may have some haze, and we want to go ahead and remove the contact lens at that point if we feel comfortable. Sometimes I've had some patients where we have to leave it, especially if sutures were used in the conjunctiva. because that's very irritating. So we use a very large, wide diameter contour contact lens to kind of baby the area so that they're not feeling it all the time while a lot of that swelling's coming down. Go ahead and check at that point. You definitely want to make sure you don't have any wound dehiscence. That means that the wound has opened. And you do that by putting fluorescein in, and you're checking to see, are you having any pooling especially if it was either glued or cauterized. You're looking to see, is there any area where it's pooling and it looks like that maybe that conjunctiva is pulled away. Now, if you have wound dehiscence, what do you do? Well, depends on how large it is. Some surgeons I've had tell me they're, like, hey, nope, it's fine. Your body's gonna kind of fill it in on its own, and it usually does by a month. If it's too big, it may make it difficult for the body to fill it in, so they'll actually go back in and try to reclose it. They don't really like, similar to when we have sutures, right? We don't go tell somebody to get sutures when it's been over a certain amount of time, 3 hours, because the risk of infection at that point, because now you're closing over an area that's been exposed for so long, and then there's just a risk for infection there. At month 1, typically the haze should be gone on the cornea and conjunctiva should be stabilized. And at that point, if the patient had sutures, depending on the type of sutures that were used, if they are non-dissolvable, you'll probably take them out at that point, or the surgeon will. Going back to the complications, as I mentioned, wound dehiscence is really the big one here. And then pterygium recurrence, because if the patient hasn't really changed their environment, their habits, wearing sunglasses, controlling ocular surface disease, they just have the potential to have it happen again. So they do happen. And really, I would say it's maybe 20% that I see a pterygium reoccurrence from surgery. And again, it's more because of patient lifestyle and commitments to their treatments that were suggested post-operatively. So it's not something that tends to occur. Long-term treatment, as I mentioned, UV exposure, control the dryness and inflammation to help keep them from having it again. Okay. So we're going to move into polling question 3, unless we had any questions. Altitude. Someone said altitude. Yes, I know. It's drying. So actually, hold on. There we go. There's the photo. What is this? ABMD, map dystrophy. You may need to move your little poll box out of the way just to the side so you can see it. EBMD. Is it an RCE waiting to happen?
So as that's rolling in and you're letting that voice give a break, I know Dr. Lobby pretty well. He's from Pennsylvania here, and he said, why would I send a patient to a surgeon who is not able to do a cataract extraction and a DMEC simultaneously? I really wasn't advocating for that. I send patients to Pittsburgh. Sometimes the patient doesn't want the transplant. They want to go for cataract first, whatever. I'm just saying that if you're sending it for a patient and it ends up getting split, they'll always do the cataract first, because you won't want to damage the DMEC. So that's all I was pointing out. Tear evaporation and squinting also produces pterygium. You talked about the altitude, and Thomas is not getting the polls. All right. I'm not sure. Thomas Joe sometimes has a solution, but
Thomas, you may want to go back out and come back in. I'm not getting the polls either, so sometimes it gets quirky.
Yeah, we're pretty spread. Guess what? You're all right, right? It is, in fact, our dear friend, EBMD, also known as ABMD, map dystrophy, fingerprint dystrophy, Kogan's microcystic dystrophy, and also more likely an RCE waiting to happen. So unfortunately, this is just one of those things that has more names than not, but they're all the same. And it is okay to use any of them. We all understand what they are. But the base of this is the concern being the abnormal production of those epithelial basement membranes, which then, remember, when we talk about the epithelial cells and how they're produced, coming from the limbal stem cells, differentiating into the epithelial cells, and then moving from the basement up. They go from the bottom up. And if you have this abnormal production, it starts to cause these layers to build up. And when we get little epithelial cells that are trapped in there, that's actually what those Kogan microcysts are. So when we think about this, we've got this layer upon layer upon layer upon layer. What happens in nature when we have layer upon layer of soil, right? We start to get erosions, which is why I say it's an erosion waiting to happen. And that's actually one of the big concerns with this. We know that when we look at that, yeah, that's hazy. It causes distortions to vision. It's going to potentially cause them to get some, in more severe cases, halos and glare and reflection issues, but also RCEs are a concern here as well. Is occasionally autosomal dominant, but more often than not, this is not related to genetics. Most commonly asymptomatic because it depends on severity. And the other thing is, remember, one of the most common places that we'll be able to see it and why we have to lift the lid when we have our patients look down is we'll see it right here at the superior limbus area. You can usually see some more of the non-aggressive forms that are asymptomatic that you may miss otherwise. Other things, mentioning the recurrent corneal erosions, they may be having these. We'll talk a little bit more about that in just a moment. They may have some distortions or increase in that halos and glare. Now, what are we going to see? Well, corneal fluorescein staining. It's our friend, right? We got to put it in. You got to look at the fluorescein staining. You might see some matte dot lines. Obviously, I showed you a picture that was not looking even with a cobalt blue and fluorescein staining, but that was a very aggressive case, right? You may see some of those microcysts or the fingerprint-like epithelial lesions. Retroillumination can help a lot to be able to see these. So this is looking at those nice ridges that we see there with that hyperfluorescence, and we've got some negative staining there as well. Now, what do we do for these patients? We have to, because again, going back to what the underlying cause is inflammation and disruption of the function of those epithelial cells, and the differentiation of the epithelial cells and the ability for our body to essentially slough off the dead epithelial cells properly. So we have to decrease that inflammation in those MMP9s on the ocular surface. You can use sodium chloride solution, especially if these patients are on the more unstable and we're concerned that they're going to have recurrent corneal erosions. You can use ointment, you can use fresh coat, going back to some of these things that we talked about before. Now, the next step is surgical. And when do we talk about surgical? Well, a patient who is getting recurrent corneal erosions for sure, but also think about it, are they having visual distortions? Are they having those halos and glare? Is this a patient who is also thinking about or more likely needing to have cataract surgery? If they are, what happens to the measurements for the cataract surgery? They're going to get thrown off because that front surface, just like we clean up ocular surface disease and dryness before, it's because it affects the measurements, which is going to affect the patient's outcome. Now, with surgical LAMK, lamellar keratoplasty, we're actually debriding off the entire epithelial layer. And then going through, and you can do this with a Wexel sponge, and then you go through and take a diamond burr attached to an algae brush essentially, and you just clean off. And that's actually helping to improve the adhesions of those hemidesmosomes when the epithelial cells start to grow back. So it's kind of helping to improve the adherence there. Now, I'm just going to go straight into RCE here because, again, LAMK is going to be used for this as well. So we're going to come back and talk a little bit more about that. But with the recurrent corneal erosions, most often are triggered by an injury to the cornea. Now, a lot of these patients may also have already had pre-existing epithelial basement membrane dystrophy, but they can also just have an injury to the cornea, most common being a fingernail from a baby or a dog. I will confirm that they weren't lying when we were in school. Those are the two most common causes. And what happens is when the cornea then heals, it heals improperly. We get weak links between those hemidesmosomes in that basement membrane while we're sleeping. Going back to what happens while we sleep, we get cornea swelling because while we're sleeping, we get that decreased oxygen exchange for the cornea. And that swelling, when we've got these poorly, they're not like this. They're not tight bonds. They're weak, right? And so they swell and open and swell and open and swell and open. And that's why they get pain while they're sleeping. They wake up with pain and blurred vision. And this loose epithelium may or may not break open. So when you look at this, what I want you to think about is like a blister that you get on your foot, right? On your heel from a shoe. If you are the person who pops that blister and takes care of it, it's just going to grow back on its own. Now, if you don't do anything, your body will reabsorb the fluid, and then you'll have this loose tissue that's over it, and it's going to take longer for it to heal. Similar to the cornea. What's happened here is this patient is getting slight swelling, slight swelling, but then it's adhering back. Do you think that tissue is really attached properly? No. You see something like that and the patient's talking and you're like, I bet you're getting RCEs. Take you numb them up, take a sterile Q-tip, touch it. That stuff's going to slough off. And it absolutely did. And then I had to clean up the rest of the cornea because it was definitely not adhered. So when we have these RCEs, when we're treating them, it depends on our comfort level, right? If you don't feel comfortable like I do, just kind of poking at it and taking off the unhealthy tissue, don't. Send it to somebody else. But in the meantime, if you're concerned that they're getting them, lubricating, the hypertonic drops in ointment, like we were just talking about with an EBMD, which is also a potential cause for this. You can do pressure patching, topical steroids to decrease the inflammation, which may allow for it to heal better. Oral doxycycline, again, decreasing the MMP9 so that maybe we get a little better adherence of those hemidesmosomes. Bandage contact lenses to protect the surface. And then you can do either surgical, an anterior stromal micropuncture, which I've never done, nor I have any patients who have ever had that done. Typically, we're going towards the epithelial debridement or LAMK. So obviously, I'm not a surgeon, so I do an epithelial debridement. You have loose tissue. That tissue is open. This tissue should not remain. I need to remove it. I'm going to remove all of it. And it's really important to go ahead and I usually use a Wexel sponge and I'll kind of push out that tissue till I get to the edges. And then I'll take my jewelers and I'll do a circular motion to kind of remove all of that tissue from the periphery. And it'll keep going. The tissue will still keep coming off if it's not adhered. If it's adhered, it won't move. You'll know when you're done. But you don't want to leave that loose tissue because it's not going to heal properly. So you see that rolled edge that's down there? That needs to be removed. We don't want to leave those. We want to get those off of there. So that chronic relapsing breakdown of the corneal epithelium with that loose adherence of the epithelium. Let me get to we already went there. There we go. So back to the LAMK. We want to remove all the way down through the epithelium. And then afterwards, so what do we do for these patients? So whether we did this for ABMD or RCE, or we're doing this for very superficial corneal scars, band keratopathy, or Salzmann's nodular degeneration, afterwards, we want to treat the surface like a baby. We want to be as nice as we possibly can to it. We want to decrease any possible irritation, mechanical rubbing, things like that. So in my treatment comes from my experience with my surgeons. So I know that this may not be how everybody does it, but this is how I have done it in the years. Maintaining a bandage contact lens for 3 years, for 3 months, not 3 years. We change it out at 1 week, we change it out at 1 month, and then a month again. Maintaining an antibiotic, doxycycline, usually a low dose of 20 or 50 milligrams, depending on the patient. And that's maintained for 3 months as well. Topical antibiotic, I mentioned, topical steroid, we're trying to decrease any risk of, very similar to PRK. We want to reduce the risk of scarring for these patients. So that's tapered over 6 weeks. And then vitamin C to promote corneal healing. Okay. Moving into the next topic, we've got our polling question 4. Which of these 3 patients has limbal stem cell deficiency? Vitamin C is oral. 500 milligram or 500, 500 milligrams twice a day. And that's usually for like 6 months to a year.
Did you see the question on, maybe you covered it, the doxy dosing?
I did,
I
yeah,
knew one do
20 to 50.
a low
Yeah,
dose. I
20 to
know
50
that.
milligrams. They come in the 20 or the 50. So you could do 20 or 50, depending on insurance, patient size, patient's tolerance. You could start at the 50, and I just do it QD, and I do it for 3 months.
And then
I try to be nice to their system.
And then Jason made a comment here. I learned from a corneal surgeon I used to work with to put the patient with recurrent cone erosion on Mura 128 ointment for 6 months after to allow less swelling. Works great. Hardly have patients return from the episodes.
Yeah, and I don't, if it's only occurred once, if you're aggressive when it's occurred the first time, especially from like an abrasion or something like that from a fingernail, I find that they tend to not reoccur very often. It's those patients that keep having it occur every night, and it's just, just a little bit. That's where it's like, we got to do something. Okay, all of the above. Well, let's look at these. So when we talk about corneal staining and we talk about limbal stem cell deficiency, it's really important to look at the staining and describe it, right? So all of these you could very easily say have 3+ SBK, but you should really describe it a little differently, right? So the patient on the left, we've got 3+ coalesced inferior half SBK. Might be from CPAP, right? I don't see any stippling. Depending on the picture, maybe I'm a little off, but we could, looking at it again, might have limbal stem cell deficiency because it's got the right kind of environment. Patient on the far right, we've got 3+ diffuse SBK. I'd be concerned for metamacosa. What have they been putting on? Are they a glaucoma patient who's been using something with BAK that they're having a reaction to? I don't really see any stippling in there. They might, though. Again, that's why we got to take a good look. But for certain, B in the center absolutely has limbal stem cell deficiency. And it has, when we talk about limbal stem cell deficiency and the staining pattern that we see with that, this patient has a staining pattern that's superior, might be temporal or nasal, depending on the eye. And it's really in this one concentrated area. And we see that the pattern is kind of making this whirl-like direction. And we also see that the staining itself is not this very punctate stain. It's more elongated, kind of like rice. And that's actually called stippling. And the reason that that forms is because of the limbal stem cells and the the epithelial cells and how they grow in. And limbal stem cell deficiency, it's not one or the other, right? Very well, could either of those other pictures still have a little stippling someplace else that we didn't see on there? But also, those patients are at risk for developing limbal stem cell deficiency. Anytime we have poor functioning limbal stem cells, we have that risk. And they are so important because they actually are what is repopulating that cornea epithelium. We might see the stippling that I was discussing. We might see some late sodium fluorescein staining, and I'm going to show you a picture of that. We may have epithelial opacities. It depends on where they are within the within their diagnosis. So again, talking about the limbal stem cells and how they kind of march from the limbus up and in, and that's why we get the very specific vortex pattern here. Now, this is a very progressed limbal stem cell deficiency patient. This is not the ones we were looking at, but as the cells start to march in, that's why we get that vortex pattern there. Now, who gets limbal stem cell? Again, it can be many different things that cause it. Inflammatory is typically the cause. Mechanical rubbing or mechanical damage from, so a poor fitting contact lens, or somebody gets a kind of trauma from chemical, something that causes damage to those stem cells. And a lot of times those stem cells may not be completely dead, they may only be stunned, especially when we're talking about inflammation. And if we remove the underlying cause and get the inflammation off the surface, we may get an improvement for these patients. So conjunctivalization is the next step. What happens? The body says, okay, cool. We're not replacing these epithelial cells with the cells we need. We're going to start to march in our conjunctival cells to replace that. So that's not ideal, right? And this is where we actually get the late stain. So when you put sodium fluorescein in there, you're actually going to get these areas where we see kind of like this whitish ridge. You're going to get stain that's going to adhere and kind of stay in that area as well. Past that, this is where we go. This is definitely that last stage as far as our limbal stem cell patients. So this is what we do not want. And it unfortunately can progress and get there if we don't fix and remove the underlying problem. So for these patients, we have many options, right? Non-surgical, again, going back to what is the underlying problem, remove any traumatic or toxic insults that might be causing it, refit the patient in a good contact lens if we're concerned that it's a poor fitting, maybe tight contact lens. And then we want to improve that tear film and control the inflammation using whatever we got at our disposal. Vitamin A ointment, topical steroids, cyclosporin, amniotic membranes or membrane drops, autologous serum drops, oxervate. This is a whole lecture in itself of different things that we can use for ocular surface treatment. Now, past that, there are surgical options. The most common one is actually an autograft, meaning that it is coming from the patient's own other eye, so that we have decreased risk for having any kind of rejection. And there's a much higher risk for rejection in these patients because what is there? A blood supply. Where the limbus has a blood supply. And so these patients are actually going through a much more rigorous anti-rejection protocol, which is actually put together by Cincinnati Eye Institute by the doctors there. And so you can see this is a 3-year protocol for these patients before they're off of their medication for anti-rejection. So I'm actually going to move to the photo. So we want to watch for rejection from day one, but they do still continue to have that risk the entire time. Late failure, a lot of the signs are going to be very similar in these patients as they are to their initial presenting problems with these stem cells failing. We're going to start to see that stippling coming. We're going to start to see conjunctivalization. So it looks very similar. And the treatments, again, are also similar. Make sure, 1, they're being good about their anti-rejection medications. 2, corticosteroids, getting the inflammation down. And then there's the potential that they might have to have a repeat transplant. Last little bit here, we're going to get into NK. Now, when we talk about this, a lot of these patients look similar. So is this a patient who has neurotrophic keratitis or limbal stem cell? Both, right? We see some of that stippling I was talking about. We see the conjunctivalization that's happening, but how do we know somebody has neurotrophic keratitis? By checking the corneal sensitivity. So we have to check corneal sensitivity. And I did in this patient. He absolutely had NK because he was such a progressed stage as far as this. And we also know the limbal stem cells, the epithelial cells, they provide the trophic support for those corneal nerves. So if they're not functioning properly, are we probably going to have NK? Yeah, we are. So in neurotrophic keratitis, this is where we have impaired corneal trigeminal innervation. And this can happen anywhere within that trigeminal nerve, anywhere from the corneal surface all the way back to the brain. So anywhere we have damage to that trigeminal nerve, it can go anterior grade or retrograde and cause damage. This leads to impairment of that trophic supply. That leads to corneal epithelial alterations, impairment of the corneal healing. So again, going back to my patient who also had LSCD, is it chicken or egg? I don't know, but I'm pretty darn sure for him, it was LSCD was the first problem. We then start to have an impairment of trigeminal reflexes, which helps to reduce tear film production, leads to reduction in tear film production and blink rate. Now we do have 3 stages, and it's important to remember we've got 3 stages as far as NK. We've got stage 1, which guess what? What does that look like? Looks like your dry eye patient you saw yesterday, right? It does. The only difference is somebody checked corneal sensitivity and said, oh, that patient who looks dry, who has no pain, probably should have pain. That doesn't make sense. Let's check the corneal sensitivity. Stage 2 is when we move into a persistent epithelial defect. And stage 3, guess what? Now it's infected and we got a corneal ulcer, and we're concerned that that could go into full corneal perforation. So how do we check corneal sensitivity?
So this is
So we've got 2 options here. We've got both quantitative and qualitative.
Quantitative, we're talking about the
And
right here.
can you
And this
hear
is what it
that?
looks like. It's a nice little
I don't know why I was doing that. So with the cotton tip applicator, so we've got 2 options. We've got our Cochet Bonnet. The Cochet Bonnet is a quantitative option. If you are lucky enough to work in a office where you have a Cochet Bonnet, beautiful, great. Use it, absolutely. I'm getting better about remembering I have mine and grabbing it so I can check it. And it's good because then I can have a better quantitative number to say, hey, you were here last time, you're here now. But guess what? That's not always the case. And guess what we do have? We have cotton tip applicators, and we also have floss. So these are 2 other options that you can use. Make sure that you're using a sterile cotton tip, and then make sure that you don't use mint floss. But you're going to tweeze out a little piece of that cotton tip applicator, twist it, and then you're checking. And you want to make sure that you check not just in the center, you want to check in all 4 quadrants and in the center. Because you may actually have one area that's got decreased innervation and function, whereas the other areas are fine. So you don't want to miss that one area is struggling while the others are okay, or vice versa. And then what do we do for these patients? So we've got many, many different options. When we talk about it, we have to think about the stage, and they all build, right? Everything I'm going to use in stage 1, I'm still going to use in stage 2 and stage 3 because it's still just the good baseline things that we need to use. Remove any ocular medication that may be associated with toxicity. We want to avoid preservatives. Obviously, now we have to make sure that you've got a good poignant brand, right? So we don't want to use generics right now or ever. We want to avoid those. Tears, ointments. Treat the other associated ocular problems. So limbal stem cell deficiency, we were talking about ocular surface disease and dry eye, exposure keratitis, if they are sleeping with their eyes partially open, vitamin A ointment, amniotic membranes, autologous serum. We can also talk about PRP, which is really hard to get, but is also great. And then also amniotic membrane drops as well. Steroids are great to calm things down. That's not a long-term treatment, but in these patients, you probably need to use it. Sorry. So stage 2, all of stage 1. I'm going to take 2 seconds. Okay, all of stage 1, but now we need to try to promote that healing of the epithelial cornea to keep it from becoming an ulcer. So put an antibiotic on there, right? We want to make sure we're monitoring these patients frequently in a bandage contact lens to try to keep the mechanical rubbing from happening so that we can maybe allow them to heal. Last polling question as we move into the last little bit here. Going back to what is our staging and remembering what the stages are.
Quick question came in asking if you were using a sterile cotton tip applicator in a sterile manner. Do you really need to use a sterile one, or would a regular Q-tip be okay?
Well, if you have a patient, I try to. I try. Hey, look, we got to do what we got to do. We only have what we have. I try not to use the ones that come in like the large pack where I've been grabbing stuff out of it. I try to get one that's in its own individual package, and then I use forceps. I just tweeze it out and kind of twist it. So I try, especially if it's somebody who's got either an ulcer or an unhealing corneal abrasion, which is, I was gonna say, which is stage. Answer to our question. There you go. Yep, stage 2, unhealing corneal abrasion. Stage 3, we're going to consider heavier antibiotics. Now, when we're talking about different treatments here, we can't, we've talked about the autologous serum, and we've got good studies that show autologous serum helps with NK, as well as we also have lots of data showing that vitamin A helps with the function and proliferation of our epithelial cells. But more recently, we also need to make sure that we mention Synedgermin, which is structurally identical to endogenous nerve growth factor, which is naturally present in our ocular tissues, but missing in our patients who have neurotrophic keratitis. I definitely would say I have had really good results in all my stages. So stage 1, I have used it in stage 1 patients, as well as my stage 2 and stage 3. It is indicated for all 3 stages. And with the trial outcomes, I think the two things to take from this is that up to 72% of the patients who were in phase 3 trials had complete corneal healing, while a year later, they found that 80% of those patients still maintained corneal healing. What I would love to see is what was their corneal sensitivity, right? Because that's really important for us. Even if that corneal epithelial cells heal and that abrasion's gone, did we fix the nerves? Do we have better function? Because if not, we're going to continue to have breakdown. In the last 2 seconds here, we're just going to briefly go over corneal nerve surgery. I think it's worth mentioning because I'm starting to hear more about this. I've never had a patient who's had this. It's really interesting. And there's 2 different ways to do it. There's direct neurotinization and indirect neurotization. So utilizing different nerves within the body, they can essentially kind of replace the nerves that we have in there. So direct, they have, again, multiple options here, but ipsilateral grafts used to shorten the operative time to extend, they dissect the area and then actually put in the ciliary nerve. And again, there's many different areas where they're getting it from, but with direct, it's typically coming from either the patient's contralateral supraorbital or supratrochlear nerve. Disadvantage here is it is a large incision, which can cause some concerns for alopecia, surgical time, a hematoma. The other surgery that they talk about is the ipsilateral infraorbital nerve direct neurotization. And so this is actually going from the inferior portion of our trochlear nerve, supratrochlear nerve. So this is just one of those really interesting things that I wanted to make sure that I shared with you. I don't have a lot of insight into this and how well it works, but I think it's worth knowing that it's out there, especially in those patients, because I've had patients patients and other doctors say, okay, well, what if Oxervate doesn't work? What if everything you're doing doesn't work? Well, guess what? Now I'm going to be finding somebody who does one of these and saying, okay, let's talk about options for my patient. Is this something that we can do for them? So with that, I'm going to open it up in the last couple of minutes to questions. I know I want to be respectful of everybody's time. It's late for some of us, depending on what coast we're on.
If you can unshare, that would be great, and I'll share mine.
Yeah, I think
So
you're
go
all
ahead and
caught
run
up
the
on
questions.
questions. I think you're all caught up on questions.
Perfect.
So Cecelia, I'm going to show 2 quick videos here that I would be more than happy to share with you. It's a great presentation that you did. Just real quick, this is a patient. This goes back to your recurrent corneal erosion talk. I'm going to start this video. I'm going to get it about here. This is a patient going an old way PRK, photorefractive keratectomy before they were using alcohol. My point of this video is not to critique the procedure, but to show how hard the epithelium is to get off. You can see them scraping here. You can see the cornea indenting. And then you beautifully talked about recurrent corneal erosion. Here's a patient, red eye, sending this for PTK before all the other treatments that you talked about. But I love this video because it just shows this diseased epithelial. Watch how gentle this is here. I mean, it just, the other one they were scraping, here it's just lightly touching. And, it just basically goes limbus to limbus.
Yeah.
And I'll clean up corneas just like you did with a Wexel sponge at the in the office when these recurrent corneal erosions come in, and before maybe doing amniotic membranes or whatever we're going to do in the office, doxycycline and all that fun stuff. And I remember one of the first times doing this and looking at the technician as they're handling me Wexel sponges, and we're going limbus to limbus. So I was like, "Ooh!" So,
Do you ever? Do you ever use a diamond burr? I got one for my algae brush.
I have not.
Yeah, and you can just do it yourself in the slit lamp.
Sounds like a great Christmas gift.
Yes.
All right. So, Joe, any other questions roll in while we were showing those videos?
No, we're all good.
Perfect. Cecelia, thanks. Great job. We're going to be seeing Cecelia back here in a few weeks, as you'll see in in an upcoming slide. But that will conclude co-managing the complex cornea. Cecelia did a great job. We appreciate it. She was our presenter, and Joe and I were moderators here.